Welcome everyone. It's good to see you all here. Like we've got a pretty big crowd today. We are here to talk about the Lunch and Learn today, and we're going to release our product on meth use and focus. So it's good to have you all here today. In the chat, we're going to also put our data brief there for you to download. And later on today, during our session, we'll ask you to look through that a little bit. So make sure you download that and get that ready. You guys get the early release of the product. We haven't put it on our website yet. So thank you all for being here. And as a reward, you get to look at it first. So congrats. In the chat, please also put your name, your role, and where you're from, and that'll help us see who we've got in the room today. Thank you all. So again, we're here to talk about meth use and focus, part 3, our lunch and learn. We will move through this pretty quickly because we have a lot to cover in an hour, but we're so happy to see you all here. I'm Nicole, and Katie's also here, and she's going to be starting us off today.
Wonderful. So yes, welcome. We're so glad to have you here. Thank you for joining us. Do take a second and download that data brief in the chat when you are able. You can go to the next slide, Nicole. So this presentation today and our data brief are both been prepared by the South-Southwest Prevention Technology Transfer Center. The opinions expressed herein are the view of the authors and do not reflect the official position of the Department of Health and Human Services or of SAMHSA. During our time this morning, we are going to help list some of the significant findings from the meth use and focus data brief that impact your local area, and also identify ways that you all can use the meth use and focus data brief findings in your own prevention work. And thank you to everybody who's introducing yourself in the chat. All right, our roadmap today. So we are doing some introductions right now. In a minute, I'm going to turn it over to Nicole, who's going to go through some of the background on methamphetamine use, some of the quantitative meth use and mortality data that we pulled together for this brief. Then I'm going to talk a bit more about the qualitative socioecological drivers of methamphetamine use, and really specifically focused in the South-Southwest region. Nicole's going to talk about implications for prevention, and then we have a little bit of time for Q&A, and then of course we're going to ask for your feedback before we wrap up today. So at this point, I want to just introduce our data team briefly. So Nicole Shamborn is your presenter today. She is our evaluator. I am Katie Chicoyan. I'm the epidemiologist. And we also have Sheila Boswell, who is our evaluation and design coordinator. And all three of us have really worked together to bring you this data brief. Nicole, who is going to bring us through most of today's presentation, she brings 20 years of award-winning public health experience to the South-Southwest Prevention Technology Transfer Center. She currently oversees all evaluation reporting and analysis and manages the evaluation database for the South-Southwest PTTC. She plays a vital role in providing high-impact training and technical assistance services to the prevention workforce, emerging prevention professionals, organizations, and community prevention stakeholders. Ms. Shamborn develops innovative program evaluation so that state and community level prevention practitioners can achieve successful outcomes. Nicole works with states and tribes to develop processes and programs that achieve long-term public health impact. Specifically, she collaborates with subject matter experts to guide states and tribes in the design of effective logic models, methods, and evaluation plans. Nicole works to create supportive and responsive research environments that interconnect services to reduce adverse public health outcomes. Nicole holds multiple certifications, namely she is an internationally certified prevention specialist and an adverse childhood experiences interface certified instructor. She received her master's degree in experimental psychology and her bachelor's degree in psychology from the University of Central Oklahoma. Nicole, thank you so much for being here today, and I'm going to pass it to you to walk through this.
Sure, thank you, Katie. And I really have enjoyed seeing all the different folks in the chat from all over the nation, which is awesome. And I just have to say that I would not be here doing this without the data team. So I really thank Katie and Sheila, and as well as our tech team, Wanda and Richard, for all the hard work that has happened behind the scenes to bring this to you today. So we also have a link for our data brief. And Sheila, if you want to post that in the chat there, it's got a link to our direct data brief as well. So you can have that as we go through today. All right, so the background of methamphetamine, and we've kind of talked about some of this in parts 1 and 2, but I know some of you probably were not able to attend our first 2 parts, so we'll briefly review this as well. So meth, as you know, is a highly addictive stimulant. It has short-term euphoria, long-term health and social harms and consequences. It can be used via smoking, snorting, injection, or ingestion. And so we have a couple ways that we have looked at the data we're going to cover today in our methodology. And what we did for the quantitative piece was look at the National Survey on Drug Use and Health, otherwise known as NSDA. And that's the website for that there. And then we also took a look at CDC Wonder, and that's going to focus mostly on our mortality data that we looked at. So that's the website there for CDC Wonder and NSDA, both great resources for you also as you look at the data for your states. So let's talk about use data first. And we have some trivia. And you have a link to the data brief in the chat over there, and our Meth and Focus series as well. Just want to point that out. But for those of you that have attended in the past, or for those of you that want to guess, which of the following states are among the top 10 in terms of methamphetamine use rates?
Which of the following states are among the top 10 in terms of methamphetamine use rates? Choices are New Mexico, Oklahoma, Louisiana, Oregon, or all of the above. And this time I see lots of answers coming in quickly. So,
It was a trick question.
yeah, absolutely. Now you know what question's coming, though.
Oh, no surprise.
And I'm seeing in the chat too, we've got a lot of weighing in. Actually, a lot of E, all of the above. We've got some New Mexico, Oregon. Yes, excellent. Okay, let's end this poll and let's see if everybody can see the results. You should be able to see them. So it looks like you all voted for all of the above, followed quickly or closely by New Mexico. And so the answer to this one is, in fact, all of the above. And I will turn it to Nicole to show us those stats.
This is our US map, and this is from the National Survey on Drug Use and Health. So you can see that states in our region, and I'll just name those, which are New Mexico, Texas, Oklahoma, Louisiana, and Arkansas. We have several states in our region there that are a little darker and indicate we have some more meth use going on in our region, all but the state of Texas there. So let's dig into that a little more. And so what we see from 1999 to 2021, we saw that 50-fold increase in meth mortality rates nationally. At the same time, we saw an increasing proportion of deaths that co-involved heroin or fentanyl. And we saw adult meth use rates, looking at that map that we just saw, in many of our Region 6 states that are significantly higher than the national average. And also for youth, we saw consumption rates in Arkansas, New Mexico, Oklahoma, and Louisiana also exceeding national rates. This graph breaks it down a little more so you can easily see it for our region. So for the US average on adult meth use, it was at 1.03%. But then if you look at our states in the region, all of them are higher than the national average, except the state of Texas, with New Mexico topping out at 1.94%. Louisiana following at 1.64%, Oklahoma at 1.61%, and Arkansas at 1.55%. So we have a pretty significant meth issue in terms of use in our region compared to the US average. Now let's look at mortality rates, and I'm going to turn it over to Katie for some more trivia.
So we'll launch the next poll, which will be the correct one this time. Um, Perfect. So methamphetamine mortality has increased drastically in the past 20 to 25 years. At what rate has it increased in Region 6 from 1999 to 2023? And your choices are 15 times the 99 rate, 37 times, 25 times, or 56 times. We'll give folks a second to weigh in. I see responses coming in. Great. Interesting. We've got a pretty even distribution as they come in. I'll show you
We
all what's
do. We do.
responded. Mhm. All right. Getting your responses real quick. We're going to close the poll in 3, 2, 1. Here we go. I got to make it a little fun, right? We're talking about mortality rates. There's nothing really fun about that. So here we are. So it looks like there's a pretty even split in your opinions between this 37 times the rate, 25 times the rate, and 56 times the rate. And in actuality, between 1999 and 2023, that rate has increased 56 times the 99 rate. Nicole, I'll pass it back to you.
Sure. Thanks, Katie. Yeah, it looks like some of you were surprised that it was that high. So, yeah, it's quite surprising, really, that we've had that drastic increase since 1999. All right, so also looking at the mortality rates broken down by state, this chart really, I think, drives home that steep increase that we've seen. While we talked about the rate being 56 times since 1999, you can see that that really big spike was kind of happening around that 2019, 2020, kind of around the time of COVID. And so we've started to see some drops recently. Like if you look at Arkansas and you look at Louisiana, and then New Mexico is kind of leveling out and after a little bit of a decrease there. But overall, though, we still see really, really high rates of meth mortality in our region. If you look at the total US, the dotted line there, that is showing where we are nationally. But if you look at most of our states, they are Louisiana, Oklahoma, New Mexico, above that, even for 2023, with the states of Texas and Arkansas below that for 2023. But looking at that spike, you see that a lot of our states really saw those significant increases in meth mortality during that 2019 to 2021 time period. So interesting to look at things this way. We try to break down charts this way so we can see those nuances and help you see visually how that works. All right, so we want you to practice with the brief. This is a lunch and learn, and we are releasing our brief today. Sometimes I call that the data brief release party. So we're happy that you all are here with us. We've been working on this brief for a while, really, several months in the making. So in the chat, you will see the new data brief there, which has a lot more detail on what we're covering today and some of our methods. But right now, if you'll turn to page 6, this will start showing you our maps on mortality for your states, and it will show the time period with the example here from Arkansas, the meth crude rates, death rates by county with your overall increase from 2016 to 2019 to 2020 to 2023. So for example, in using Arkansas here, they saw a 107% increase in the crude death rate from 2016 to 2019 to the year range 2020 to 2023. And then if you look at the maps, you can visually see the increases with more areas coming up in the later year period, and also seeing those darker colors start to happen. So if you look at the bottom of each state grouping, you can see the range also. So where that crude death rate legend is at the bottom, for Arkansas, we see 0 to 16.5. And so for some of the states, like New Mexico, you're going to see a much larger range because the rates are so much higher. All right, so it's your turn. Richard's going to post a question in the chat here. So what can you tell us about the maps in your state when you look at the brief? So starting on page 6, look through the state maps for mortality and just put in the chat what you notice about your state in terms of the meth mortality and how it's changed at the county level and statewide. So we'll give you a couple minutes to do that. And Angela says more counties are affected in Oklahoma. Great. So you can really start to see that spread. Anyone else? And you can also open your lineup if you'd like to just speak. Paige says, same in Texas, a lot more counties and darker colors. Yeah, and that's interesting for Texas because Texas does have lower rates than the nation, as well as our region in general. But this is why it's important to break that down by these maps because we can start to see the increases in certain counties and the spread. And so it tells us that there's still an issue that we need to be looking at. And also Paige says that counties without colors are much more rural. Very good. That's important too. We want to look at the context. Where is it happening? Where are we seeing those increases? Where can we direct our resources? Anyone else? What about the states of Arkansas? If anyone's here, let's see, who else haven't we heard from? Louisiana.
And New Mexico too.
And New Mexico, yeah.
Mhm.
So quiet.
Everyone's really taking the moment to dig into some of that data.
That's right. That's right. It does take a bit. Well, and I kind of gave clues to Arkansas, so. But yeah, in general, over our region, you do see the counties, more counties being involved in the map and darker colors starting to happen, which indicates an increase. So it's definitely something we've got to keep an eye on. And the brief will help you look at those details at a much greater level too. So please take a look at that brief and kind of start digesting all of that.
Oh, I do see in the chat, surprising for Louisiana because some of the parishes we have high overdose rates are lower crude meth death rates.
Oh, interesting. Yeah. And sometimes, there is a lag in data too that happens, and this does just go up to 2023. And so we might be starting to see some other patterns as well that aren't reflected in these maps. So it's a great thing about data, and the bad thing about data is it's always updating. So appreciate that, Charmaine. All right. So I'm going to turn it over to Katie. We've looked at the quantitative data now, and as always with quantitative data, it is great, right? But it doesn't always address all of those gaps that remain. And so Katie's going to talk a little bit about those questions that we have that are remaining.
Thanks. And so these questions actually came from folks like you all who came to the first part of our series. So in the first part, Nicole presented our quantitative data, some of what we've talked about this so far today, and in a little bit more depth than that. And then we asked folks on a Padlet to share with us what questions they still had. And so here's what you all came up with. And Nicole, if you would just click through those
Sure.
prompts. Great. So one was, is there any link between meth use, fentanyl use, and homelessness? Another was, why is there a resurgence in use and mortality now as opposed to other points in time? What is happening in the small communities that have suppressed data, which we know happens more frequently in rural and frontier counties? And for anyone who's not familiar, suppressed data would be when there's just low enough response rates that we're not able to report that data, or the national data sources are not able to report that data while maintaining the sort of confidentiality standards of the surveys. What are the most recent trends from the last 1 to 2 years? As Nicole mentioned, there is a data lag. And so what's been going on in 2024 and 2025 here? What are the impacts of COVID on meth use prevalence? How has COVID specifically influenced what we're seeing in these numbers? And then finally, what are those reasons for usage? What are the underlying needs that are not being met that are driving people to use at these rates? And so, as Nicole said, there's other ways to gather this data that maybe doesn't show up in our large scale epidemiological quantitative data sets. Before we get into that, though, we do have another trivia question for you. I'll let Nicole do that one.
Sure. Thanks, Katie. We're doing a lot of trivia today. What can be done to address the remaining questions about meth use and mortality? Richard's going to bring up that poll. So we'll let you
Sneak
all.
peek of this one before.
Oh, that's right. This was the sneak peek. All right. That means you guys should be prepared to answer this one, right? All right. We're getting a few in. Looks like we've got primarily two answers coming out of this one. So, all right. So it looks like we've got about 40-ish people who have answered so far, and the majority are saying collect qualitative data via focus groups with people who use methamphetamine, with the second being conduct interviews with providers who work to support people in recovery. And no one, not hardly anybody said consume media like Breaking Bad. I'm disappointed. I'm disappointed, Katie.
I told you, I tried to make it fun.
And I am glad to see none of you said nothing, because there's always something we can do in prevention. There's always a solution, right? And that's what we are good at. So I'm really glad to see this. No one said nothing. So very good. And I will turn this back to Katie.
Thank you. So just as you answered, there were actually two correct answers on that one, right? We want to incorporate, sort of starting with our quantitative data, adding some qualitative data to really understand through a mixed methods approach what's going on here. Sometimes we might talk about this as triangulation, right? So we're trying to get data from multiple data sources that helps us understand the more full picture of what's going on. So we are going to talk a little bit about qualitative data at this point. And we can go to the next slide. I'm sure anybody who's been involved in our in the Southwest PTTC services webinars the past year has heard me talk about qualitative data. But in case it's new to you, qualitative data really are words and images and other non-numerical data pieces that we can use to understand the bigger picture of what's going on. It's interpretation based, it's frequently descriptive, it's based on experience and perception, and it can be collected through a number of methods, including focus groups, listening sessions, questionnaires, key informant interviews, and observations. It helps us really understand how, why, and exactly what happened behind certain behaviors, rather than these questions of like how much, how many, how often, that really get answered by quantitative data. It calls in context and meaning to data. It can give voice to participants, especially all participants, and especially those in smaller sample sizes and groups that are less represented in quantitative research. It allows for flexibility, it allows for uncovering unexpected patterns or relationships, and it can really help support our interpretation of quantitative findings. And we can use this sort of paired mixed method approach either in the way we're doing today, where we sort of have this quantitative data and we want to better understand it, so we're going to investigate some qualitative data, or you can use the qualitative data to inform the quantitative data that you're going to be looking for. So today, what we're going to look at and what's included in the brief are really 4 different studies from the past 5 years that all looked at groups that had shared some similarities with the population in the Southwest around methamphetamine use. The first study that we looked at was from Hansen et al. This is a 2021 study of qualitative interviews with 20 Appalachian Kentuckians who reported lifetime opioid use as well as past 30-day methamphetamine use. The Harding study is from 2022, and it's of 21 qualitative interviews with people over the age of 18 who reported meth use in the previous 3 months in both Nevada and New Mexico. The Ondoxin 2023 study was a rapid ethnography that did include semi-structured interviews of 30 people who injected heroin and or fentanyl and also used methamphetamine, and that was in West Virginia. And then the last study is a 2021 study by Silverstein et al., which reviewed interviews with people who use both heroin or / fentanyl and methamphetamine in the metro area of Southwest Ohio. So all of these have sort of touch on concurrent use of meth and opioids. They're with mostly rural groups. And in one case, we do include information from one of our Southwest states, New Mexico. Each study revealed insight into one or more of the levels in the socio-ecological model that can help us better understand the reasons and contexts in which people are using methamphetamine. The next slide, Nicole. I know that many of you are familiar with the socio-ecological model. This is a way of understanding individual choices and health outcomes that really looks beyond individuals to understand the multi-levels, the interpersonal, community, and society level that are really impacting them as they move through the world. This particular graphic is adapted from one of those studies I just mentioned, the Hansen et al. Study from 2021. They mapped their findings onto the socio-ecological model. And so what we did as we added some additional qualitative data from these other sources was add them into this model as well. So we could really see kind of a visual of understanding what are the different factors and drivers that are occurring at each level influencing meth use in the Southwest. And that way we can use the information to plan our prevention efforts. So we are going to go into just a snapshot of the data. There's a lot more in the brief, but just to give you an overview, let's take a look at the next slide and look at some of the individual level factors. You would click, there we go. So at each level of the socio-ecological model, there are factors that are influencing meth use. At the individual level, meth is often used as a tool to suppress withdrawal from other drugs. Participants described how meth use helped to suppress withdrawal symptoms and cravings for opioids. And several participants who have been prescribed buprenorphine for opioid use disorder reported being removed from treatment after they tested positive for meth, which led to opioid withdrawal and increased their use of methamphetamine to treat their withdrawal. Nicole, would you mind just reading this quote for us from one of the participants?
Sure. You do it right away, and you just get lost in what you're doing, and you forget that you're sick. It does actually take away some of the sickness. Then you do forget that you haven't done heroin in 4 days.
Thank you. And so participants are describing going sometimes a day or a couple of days without using heroin. Yes, because their symptoms are somewhat addressed, but even more so because time is so fluid, they can get so lost in time while on meth. And that's one of the reasons individuals report using it. Shifting up a level in the socio-ecological model, so we're looking at this interpersonal level, social access and ease of access among family and friends really influence meth use. Nicole, I'll have you read this one as well.
Sure. I don't really like meth. My boyfriend loves it, and I do it mainly to stay up with him.
So, a social aspect really influenced several participants' use. This quote is from a participant in her late 50s who had been using heroin for 5 years and meth for 2 years. And she talked about how she really doesn't like meth, but she would use it socially to synchronize her time with her boyfriend. And this is something that we also saw coming up in the research a lot, is the way that social interactions have really influenced the use of meth. We'll go to the next slide and take a look at the community level, where we're seeing that availability and affordability of meth really influence the rates at which it's used. Participants really uniformly described how methamphetamine is now the easiest illicit substance to acquire, which has allowed for the rapid increase in new onset in the South Southwest region. And talking specifically about this form of crystal meth known as ice, participants were really shocked at the ubiquity of ice on the streets. This particular, or there was one particular person who talked about, having been incarcerated for a brief period of time when she came out of incarceration, that ice was just everywhere. Nicole, would you read this quote, please?
Sure. I don't like it. I do it often. I've never paid for it. I've never paid for it because ice, especially around here, is practically free. A week's supply of ice costs about $40.
The researchers in the Ondoxin study talked about sort of classified folks who use meth for its intrinsic value or for its potential to help with withdrawal symptoms. And then there was a whole group of folks who used what they called reluctant or indifferent use. So people who would basically say, I'm not ever seeking out meth, but if it's given to me for free, then I use it. And knowing what we know about the addictive quality of meth and the mortality rates that we're seeing, I think it's really important to understand that this is a big pathway for folks who are using meth. Finally, at the societal level, we're seeing large social conditions such as the economy that impact patterns around prevalence and of meth use and then the subsequent mortality. So Nicole, will you read this last one for us?
Sure. When we couldn't find pain pills, we'd run into people who have meth. We'd done meth. The doctors has cracked down writing, probably around last year, I guess. I think if there had been more pain pills, I don't think I would have started doing meth. I don't think.
Thank you. So this was from a former coal industry worker and represents a whole sort of group of participants who really linked rising rates of meth use to poor economic conditions. And as they saw these sort of shifts from higher paying jobs, like those in the mining industry, to minimum wage employment, they were also seeing the uptake of meth use. These are quotes that are directly from the individuals interviewed in the studies. As you saw, there's some what look like typos, but they're really just connections directly in the words of those who have experienced this. So as we put all this together, we're looking at the quantitative data, we're looking at what we're seeing from qualitative data. It kind of brings us to this place of what can we as preventionists do? I'm going to pass it back to Nicole to talk through some of those pieces.
Thank you, Katie. That was just a beautiful job of covering all the qualitative data. And thanks, Katie, for bringing all those great quotes to us. I think it really sheds a lot of light on the context behind what we're seeing in the quantitative data. So what can we do as prevention professionals? This is really where we can put our heads together. We can use the SPIF framework to try to figure out how we can address these issues. And so in your brief, you'll see a section on what we can do as prevention professionals. And I want to highlight some of those things or ideas here as well. So one thing we can do in terms of data is we can look at local use patterns and overdose trends. So we have a lot of data on the national use and mortality rates. We also have from CDC Wonder where we can break those mortality rates down by county, but that still doesn't paint the whole picture. And so really digging in and looking at those local use patterns is important. I know when Katie and I were at the National Prevention Network conference, we had a participant that mentioned looking at county level data and getting that from your local oh, I'm drawing a blank on the name, Katie.
Coroner's
The
office.
coroner's office. Thank you. So, making sure you reach out to those partners and thinking about creative ways to get that data. And so, making sure you establish those relationships with people that we're really good at doing as prevention professionals, but we don't always think about it in terms of data. Who are the data partners we can work with at the local level? Another way to do this is to reduce barriers related to ACEs and root causes. And so addressing things early on, as we do in prevention, really concentrating on reducing adverse childhood experiences as much as we can, making sure we implement programs for families, like strengthening families, some of those evidence-based practices that we already know how to do, but really kind of honing in on that at multiple levels, and those shared risk and protective factors is extremely important. We also can conduct overdose prevention education and naloxone distribution. So in some of the qualitative data and some of the quantitative literature, we see that in rural areas in particular, there is a lack of, overdose prevention education and naloxone distribution happening. And so how can we reach out to those areas and make sure that those things are going on to reduce some of the consequences? We also can work on normalizing and destigmatizing screening and treatment for substance use and mental health. So even at places of work, things like that, rural clinics, county health departments, all of those things, we can work on normalizing the language so that people don't suffer from stigma. And a lot of the times that's what's preventing people from accessing those services. We also can promote workplace prevention policies and practices, making sure our workers get the help they need early on. We can utilize rural and tribal approaches. So sometimes we need to take a different approach based on the context, based on the community, and making sure we adapt evidence-based practices, programs, policies, all of those things is important so that the interventions are relevant for the community that we're working with. We also can implement school policies that link students to support, um, thinking about some of those punitive measures that sometimes exist in the school system, getting those kids connected to resources instead early on and support with counseling can also help prevent some of these consequences. We also can implement universal prevention education and continue doing those approaches. And then we can also advocate for research. So something else that Katie and I found as we were doing this is that there is limited research on meth use. And so while we found more than we thought we would around qualitative data, there's still a lot lacking. And as prevention professionals, we can really advocate for those things. There are also some really cool like epidemiological practices that can be implemented, like wastewater epidemiology and tracking the amounts of certain substances in wastewater just to see where hotspots are and where are things emerging. And so we can think about really creative ways to implement things as prevention professionals as we move forward. Oh, and I see a comment from Dylan. It is refreshing to have a webinar about a growing issue like methamphetamine. So many webinars are about fentanyl, which is good, but oftentimes we forget about other emerging issues like this and ketamine. And David, yes, this is very informative as meth use is on the rise in my community in Detroit. Great. Yeah, we do talk about fentanyl a lot, and the two often overlap, and we see a lot of polysubstance use, and we often talk about the fentanyl issue, but we don't talk about methamphetamine. So I appreciate your comment. All right, so now we're going to talk about what strategies can you implement at each of these levels, and these are some thought-provoking things that we've got here under the individual, interpersonal, community, and societal level. And I'll just let you take a look at those. And you can see the wastewater-based epidemiology that I mentioned there at the societal level. So some really cool things that you can find in the literature and really start to think about as you implement some of these practices. But we're going to let you take some practice with Padlet and filling that out on some things that you can implement. So let me go ahead and bring that up. So can you all see the Padlet? And Richard has posted the link in the chat. So if you click on that link, it'll take you to the Padlet and you can start filling out the Padlet for the individual, interpersonal, community, and societal levels. What are some strategies you can implement at those levels in your community? So we'll give you a few minutes to do that. You can add your comment by just clicking the add button there, and then you'll be able to add. So I'll just do one to show you how that kind of works. So I'm adding at the individual level, I'm going to add screen. And then I just hit publish and it shows up under individual. So that's how you do that. All right, mental health trainings. Under community, we've got education, great. Providing linkages to services, very good. Yeah, we can do screening, but if we're not providing those referrals, then we're not following through and getting people the help they need. Under interpersonal, I see keep talking about that meth is real and an increasing issue. Help break down stigma around talking about it. We also see peer recovery services, conversations with others, great. And under individual, cognitive behavioral therapy. So getting at some of those evidence-based interventions at the individual level. Outreach, screening, assessment, and referral, great. And I'm moving over to community now, looking at education, information distribution at community events, support groups, coalitions. And coalitions are a great way to really advocate in your community too around decreasing stigma. So, coalition building, yeah, lots of coalitions. All right. And societal, I see some things coming through, Katie, advocating for affordable substance use disorder care. Great. Norms, funding. Yes, funding. Funding is always a thing, isn't it? Having resources and community engagement available and addressing stigma. Perfect. A few others that came in under interpersonal, we see addressing meth use while addressing tobacco use. Great. Encouraging those with lived experience to get involved. Very good. Family support programs. And under individual, we had a few more additions. Substance use disorder training. So creating some awareness there, local access and resources, education, community awareness campaigns under community. Great. Public policies under societal, right? And I would probably add also under societal some of those epidemiological methods that can be implemented at on a larger scale. And then I also see under community town hall meetings involving community leaders. Great. Societal, we also have research. Yay! We got our message through about the advocating for research. I love it. Healthcare access. Great. Yeah. All right. Well, you all are doing an amazing job, and you can continue to fill this out. So even once I move back to the PowerPoint, you can continue to fill it out even after today's webinar. We'll leave it open. So we'd love to hear all of your ideas and bring that all together to help us as we move forward with understanding this issue. And I just saw media campaigns. Yes, yes, media campaigns can reach a broad audience. It's great. All right. So I'm going to move back to our PowerPoint, but you all keep going. I love it. Keep going. Okay. So now that we went through that and went through all the different levels, let's think about what are some of the significant findings from the data brief that you feel like impact your local area. And I see letters to the editor have shown effective for awareness in my community. Great. Under those strategies, that's awesome. What are some of the significant findings from the meth use and focus brief that impact your local area? And you can place those in the chat. You can also come off mute if you like. I know that for me, as we were going through and compiling the results and putting the brief together, I think we all had a realization that often we focus on some of the larger prevalence substances, but you can definitely see the patterns in meth use in our region that are of concern. So, and Paige says we will also be doing a series of interviews with people in recovery from meth. Great. Evidence-based interventions. Yes, evidence-based interventions, making sure we promote those. And does anyone have any goals they would like to share for meth data collection and prevention in the upcoming year? Any innovative ways you're going to collect meth data, or maybe incorporate some of those qualitative things Katie was talking about?
I mean, I'm really excited to hear that you're doing some of these interviews, Paige. I'll be curious to see what you're going to do with that data if you make it sort of publicly available, send it our way for sure.
And Latanya says, educate individuals, especially youth, on the dangers and consequences of meth use to prevent initiation. Yeah, if we can really do a good job at that primary prevention, right? Moving on upstream, as we call it in prevention, getting there before things start is important. Anyone else like to say anything? Promote health behaviors, good. Healthy.
Something
I,
that really came up for me, even from that first webinar, hearing from the folks who attended, was that question of like, what are those underlying reasons people are using meth? And I think when we see the connection to using meth to withdraw from other substances, right? It's just so clear that some of those underlying risk and protective factors are a place where we want to be focusing this.
yes, yes.
Mhm.
That's so true, Katie. And, as prevention professionals, we know how to do assessments. We know how to put together our comprehensive prevention plans and really remembering that if we basically address those shared risk and protective factors, we can be getting at a lot of these issues that contribute to meth use. Let's see, Wendy, this will prompt me to research data in my area. Great, great. Educate families. Yeah. And sometimes with meth use, we see the generational patterns, right? So educating families and trying to get some of those patterns to change is extremely important. All right. Anything else anyone would like to share, or we'll start wrapping up here? Promote community involvement. Great. Yeah, community is especially important. Town halls, good. Awesome. Well, I appreciate you all contributing as much as you have. I know this is a heavy data presentation, but you all have been awesome, and I hope you really take time to look at the brief in more detail. So in summary, over the past 25 years, we've seen a 50-fold increase in meth mortality rates nationally. We also have seen adult meth use rates in most of our region that are higher than the national average. It's being driven by individual, interpersonal, community, and societal factors that Katie talked about, and then you all brainstormed in your Padlet. And then the qualitative data collection can fill in those gaps in existing quantitative data and provide that data-based assessment that we really need for comprehensive prevention planning. And think about those logic models. I'm a big advocate of logic models. Think about how you can take your logic model and really develop that comprehensive plan for addressing all those factors, including meth use and mortality. All right, so we will take any questions you all have, but we also have an evaluation for today for our lunch and learn. And we are super happy that you came and enjoyed our product release with us. So we'll continue to post that brief in the chat for you to download. We also will be sending out all the materials from today as well as a recording in about a week. So you will get all of that information then as well. But please fill out our evaluation. It's how we make sure that we are being responsive to your needs and continue to deliver high quality products and training. So please fill that out. And Richard has posted the brief there again. And I will also start moving through some of our resources here. So we have a newsletter that we've done around meth use. We also will have a product page for all of our focus on meth use and focus, basically all of our parts 1 through 3, including today's lunch and learn, as well as our recordings and the brief. So that will all be there on our product page. And then we also want you to point out the focus on meth be part of the conversation. This was kind of a a seminar that was done online that had a lot of good information on meth use as well. The National Survey on Drug Use and Health, one of our primary data sources for today, as well as the Centers for Disease Control's Wonder database, which is where we got all the mortality data from. I will also point out that in our brief, we do detail out our methodology and the codes that we used to do our data extraction from Wonder, because it can be a bit complicated. So I just want to point that out to you EPIs out there in case you'd like to replicate what we've done, that's all detailed in the brief. And those are our references for today. And that is a wrap up. So please fill out our evaluation. Katie, was there anything you wanted to say before we sign off?
Thank you all so much for being here. My mission this year has been to help people think about the role of qualitative data, the role of the voices of people who are really impacted by this work. And so I'm just excited to see that you all are already thinking about that. Yeah, and be in touch with us if you need any further sort of TA or support thinking about this work.
Yeah, thank you. And I do see a question about certificates. We will be sending out the information for you to obtain your certificate from today as well. So, and stay with us for this next year. We're starting to plan our next data brief for the next year, and I believe we'll be focusing on youth. So look forward to hearing from you on our next series upcoming in the next year around data.